1, 2,
And review, somebody email.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Imagine you are standing in a brightly lit hospital hallway. The patient standing in front of you has committed no crime.
Right.
They haven't stood trial. They haven't seen a judge or a jury. And yet, in the next 5 minutes or so, you are going to help legally strip them of their constitutional right to freedom.
It's heavy. It really is.
It is. You're going to walk them behind a set of heavy double doors. You'll hear those magnetic locks just click shut, and they will not be allowed to leave. I mean, in any other setting, in literally any other context in our society, doing this to a human being is just kidnapping.
Yeah, exactly.
But in psychiatric nursing, it's just a Tuesday. So welcome to the ultimate legal and ethical tightrope.
It is probably the most profound paradox in all of healthcare because, we are taught that nursing is entirely about healing, right? It's about comforting and advocating for the person in the bed. But when you step into the psychiatric and mental health space, you are stepping into an environment where those very freedoms that define a person's independence, like the right to move freely or the right to refuse a chemical substance entering their body, the right to privacy, all of that suddenly becomes conditional.
Which is terrifying when you really think about it.
It is. You are balancing this immense weight of civil liberties against the absolute necessity of clinical safety. And the margin for error there is, well, it's essentially zero.
And that is exactly why we are taking this deep dive today. So if you are listening to this, you aren't just trying to pass a nursing exam or memorize some textbook chapter.
No, definitely not.
You are actively preparing to be the person standing in that hallway holding the keys. You are learning how to protect your patients. And let's be honest, just as importantly, how to protect your own nursing license.
Absolutely. Your license is everything.
So we're going to break down the legal and ethical foundations of psychiatric nursing. We are looking for that 20% of the material, the absolute highest yield, must-know concepts from the sources. That will give you 80% of the clinical judgment you need to be a safe, elite practitioner.
And to truly understand the gravity of the rules we operate under today, we kind of have to look backward first. We have to understand why these strict laws even exist in the first place.
Right, because it wasn't always like this.
Not at all. For a very long time, psychiatric patients had virtually no rights. I mean, we are talking about a really dark history of institutionalization. Up until the mid-20th century, the standard of care was essentially warehousing human beings in asylums.
Warehousing. That's such a bleak word for it.
But it's accurate. These were heavily overcrowded, severely understaffed facilities where people with severe mental illness were just hidden away from society, out of sight, out of mind. The conditions were often totally inhumane. The concept of patient rights just did not exist.
Yeah, the history there in the source material is so bleak. You read these accounts of patients being subjected to experimental treatments without any consent whatsoever.
Oh, yeah.
Or being physically restrained for days or even weeks on end. And they were entirely cut off from the outside world.
Exactly. And it really wasn't until the 1970s that a massive systemic revolution in patients' rights finally took place. The legal system began to aggressively intervene. Laws governing civil commitment were entirely overhauled.
Thank goodness.
Right. The courts finally recognized that just because someone has a psychiatric diagnosis, that does not mean they forfeit their personhood. And that historical pivot is the foundation of everything we're going to discuss today. It established the reality that modern psychiatric nursing is not just about managing symptoms. It is about acting as a staunch defender of human rights.
Okay, so let's look at the baseline then. A patient walks through the doors of your facility, or maybe they're brought in by EMS. Before you can even begin your nursing assessment, before you look at their meds or their history, you have to understand the legal mechanism of how and why they are in your care.
That is step one, always.
Right. So do they just surrender their rights at the admission desk the second they put on the hospital gown?
Absolutely not. And this is a massive point for clinical practice, and honestly, it's a concept that those NCLEX-style exam questions will test you on repeatedly. Psychiatric patients retain all of their civil rights upon admission.
All of them.
Yes. They retain the right to vote, the right to manage their own finances, the right to practice their religion, and importantly, the right to refuse treatment. The only exception, and we will dive deep into the nuances of this later, is the right to leave if they are involuntarily committed. But everything else remains intact.
Okay, the source material specifically highlights the right to send and receive sealed mail.
Yes, that's a big one.
For someone new to this, that might sound oddly specific, you know? Like, why is the Postal Service getting a special shout-out in psychiatric patient rights?
Well, it goes directly back to that dark history of warehousing we just talked about. In the past, asylum staff would routinely intercept, read, or even just destroy a patient's mail.
Wow. Just to keep them isolated.
Exactly. The goal was to hide the horrific conditions of the facility from the outside world. If a patient was being abused, they couldn't write to a lawyer or a family member or a newspaper. So guaranteeing sealed mail ensures the patient has an uncensored, unmonitored lifeline to the outside world. It's a fundamental anti-isolation measure.
That makes total sense.
Yeah, so as a nurse, you cannot open a patient's incoming mail, and you absolutely cannot demand to read what they are sending out.
Okay, but let's talk about the messy reality of clinical practice on the floor. The text says rights can be restricted if there's a verifiable, documented reason. So practically speaking, what does that look like? Because if a patient is actively suicidal, I'm obviously not going to let them keep a razor blade just because it's their personal property.
And that right there is where clinical judgment intersects with the law. You can restrict your right, but you need a rock-solid, clinically justified, and meticulously documented reason to do so. The justification has to always be rooted in safety.
Give me an example of that.
Okay, so a patient has the right to their personal clothing, right? But if your nursing assessment reveals that the patient is actively planning to hang themselves, you cannot permit them to keep a leather belt or their shoelaces.
Right, that's just basic safety.
Exactly. So you remove those items, but you must document exactly why. You write, patient verbalized plan to use shoelaces for self-harm, items removed for safety. You have to prove it wasn't arbitrary.
What about visitors? If a patient has the right to have visitors, but let's say their spouse comes in and consistently verbally abuses them, triggering this massive escalation in the patient's anxiety and aggression, are my hands tied there?
No, your hands are not tied, but you do have to follow a process. You can't just ban the spouse arbitrarily because you don't like their vibe.
Right, as much as I might want to.
Right. The treatment team, which includes the psychiatrist, the primary nurse, the social worker, they all have to evaluate the situation together. If there is documented evidence that the visitor poses a direct threat to the patient's therapeutic progress or their physical safety, the team can formally restrict that specific person from visiting for a designated period.
But again, if it's not documented, it didn't happen.
Exactly. It requires verifiable documentation, proving the restriction is a clinical necessity, not just for staff convenience.
All right, so that covers the baseline rights and how they can be modified for safety. Now let's look at the actual admission status itself, because this dictates the largest right of all, which is the right to leave. Let's start with voluntary admission.
Okay.
A patient recognizes they're in crisis, they agree to inpatient treatment, and they sign the admission paperwork. Is this like checking into a hotel where you can just, pack your bags and walk out the front door the moment you change your mind? Or is there a catch here?
There is a very significant catch, and listen up because this is a classic NCLEX trap.
Oh, I love a good trap warning. Lay it on us.
So, yes, a voluntary patient has the right to request discharge. In a standard medical surgical unit, if a competent voluntary patient wants to pull out their IV and leave, the nurse educates them on the risks, has them sign against medical advice form or AMA, and they just walk out.
Right, happens all the time on MedSurg.
Exactly. But in psychiatry, the process is fundamentally different.
Because if I have a patient who came in voluntarily for severe depression, and 2 days later they want to leave, but as their nurse, I know they are secretly hoarding medication and planning to overdose the moment they get home. I mean, I can't just hand them an AMA form and say, have a nice day. So what actually happens when they demand to leave?
If a voluntary psychiatric patient requests discharge AMA, they do not get to just walk out the door immediately. They must sign a written request for release. And once that written request is submitted, a legal clock starts ticking.
How long is the clock?
It's often 24 to 72 hours, depending on the specific state laws. And during that window, the clinical team is legally required to perform a comprehensive safety evaluation.
And this is where their legal status can flip on a dime.
Exactly. If the psychiatrist evaluates the patient and determines that they have become an imminent danger to themselves or others, that right to leave vanishes instantly. The provider will file the necessary legal paperwork for a civil commitment to detain the patient against their will. Yeah, the patient's legal status literally shifts from voluntary to involuntary. You detain them on an emergency hold until a formal court hearing can take place.
So the priority nursing action when a voluntary patient demands to leave isn't to start packing their bags. It's to immediately assess their current safety risk, document their mental status, and notify the provider that a written request for discharge has been made so that evaluation window can begin.
Precisely. You are the eyes and ears on the unit. Your nursing assessment is what the provider relies on to make that monumental decision to strip away their voluntary status.
That perfectly transitions us into involuntary admission, which is also known as civil commitment. We have established that this is a massive deprivation of liberty. And the source material is very clear about this. You cannot lock someone up just because they're making poor life choices.
Right.
Right. Or because they're acting bizarrely, or just because their family finds them exhausting to deal with. What is the absolute non-negotiable legal threshold for taking away someone's freedom?
The threshold is imminent, severe danger. Involuntary admission is legally justified only if the patient meets one of three specific criteria.
Okay, what are they?
Number one, they are a direct imminent danger to themselves, meaning they have active suicidal ideation with a plan and the intent to carry it out. Number two, they are a direct imminent danger to others, so active homicidal ideation or aggressive psychosis. Or number three, which does vary slightly by jurisdiction, they are so gravely disabled by their mental illness that they cannot provide for their basic human needs of food, clothing, and shelter.
Let's break down that third one, gravely disabled, because I feel like that can be tricky. We aren't talking about someone who just has a messy apartment or forgot to pay their electric bill.
No, not at all. Gravely disabled refers to a profound inability to survive safely. We are talking about a patient experiencing such severe schizophrenia that they are wandering the streets in a blizzard wearing only a t-shirt, unable to process the physiological sensation of freezing.
Oh, wow.
Or they are eating rotting garbage out of a dumpster because they firmly believe the grocery store food is poisoned. They are not actively trying to kill themselves, but their illness has rendered them completely incapable of basic survival. That meets the threshold for involuntary commitment.
That makes a lot of sense. So when a patient meets any of those three criteria, they are placed on an emergency hold. Usually that's 48 to 72 hours. But that 72 hours isn't the end of the story. It's really just a placeholder, right? The hospital doesn't get the final say.
Correct. The 72-hour hold is just a temporary emergency measure to ensure immediate safety. During that specific window, a legal hearing must be conducted, and this is a formal legal proceeding.
Like with a judge?
Yes, a judge or a court-appointed magistrate will review the evidence. The psychiatrist must actually testify and prove to the court that the patient still meets the criteria for commitment, and the patient has the right to legal representation.
That's a huge protection.
It is. The legal system steps in to evaluate the medical necessity. It is the ultimate check and balance on psychiatric power. If the judge agrees with the clinical team, the patient is committed for a specified period, maybe 14 days, maybe 30 days. But if the judge disagrees, the patient must be immediately released.
No exceptions.
No exceptions.
So we've explored the intense legal mechanisms that happen inside the hospital walls. But the legal boundaries don't just magically dissolve the moment a patient is discharged and walks out those exit doors. They extend right out into the community. So let's talk about life after discharge. Let's look at mandatory outpatient treatment.
Yeah, this is also known as legally assisted treatment or conditional release. It is essentially the legal requirement that a patient continues to participate in their treatment plan on an involuntary basis, even after they are living back in the community.
What does that actually look like in practice? Are police officers like showing up at their house to force them to take a pill every morning?
It's not usually that dramatic, but it is legally binding. The court orders the patient to adhere to a specific outpatient regimen. This might mean they are legally mandated to attend specific therapy groups, show up for appointments at a community mental health center, or adhere to their psychotropic medication regimen.
And how do they enforce the medication part?
Often that's administered via long-acting injectable antipsychotics to ensure compliance. If they violate the court order, their conditional release is revoked and they can be involuntarily readmitted to the inpatient hospital.
The source material notes that 47 states and the District of Columbia have laws on the books for mandated outpatient treatment. Only 3 states, Connecticut, Maryland, and Massachusetts, do not. Why is this such a heavily debated, polarizing topic in the psychiatric community?
Because it sits directly at the intersection of public safety, medical paternalism, and civil liberty. It is a profound ethical clash. On one side of the debate, the clinical data is undeniably compelling. Mandatory outpatient treatment is highly effective for a very specific subset of patients.
Which patient?
Usually those with severe, persistent mental illness, like severe schizophrenia, who lack insight into their illness. These are the patients who historically fall into a revolving door. They get hospitalized, they stabilize, they are discharged, and then they immediately stop taking their medication because they just don't believe they are sick.
Right.
Then they decompensate, they end up homeless or incarcerated, and the whole vicious cycle repeats.
So the argument for it is that it breaks that devastating cycle.
Yes. The statistics show that mandatory outpatient treatment significantly reduces the mortality risk for these patients. It reduces the likelihood of them being victimized by criminals while they're vulnerable and psychotic on the streets. It drastically reduces inpatient hospital readmissions and days spent incarcerated.
Which is a huge burden on the system.
Exactly. Overall, it is vastly more cost-effective for the healthcare system. It essentially creates an enforced safety net that keeps them alive and integrated into society.
Okay. That honestly sounds like a massive win for everyone involved.
Mm-hmm.
So what is the counterargument? Why are civil rights advocates so opposed to it?
Because the counterargument asks a really chilling question. Who owns your body?
Oh.
Right. Civil rights advocates argue that once a person is back in the community and is no longer in imminent danger, requiring them to take psychotropic medications against their will is a fundamental violation of their bodily autonomy. These medications, like first- and second-generation antipsychotics, can have severe life-altering side effects.
Like tardive dyskinesia.
Exactly. Tardive dyskinesia, massive weight gain, metabolic syndrome. Forcing someone to endure that under threat of hospitalization is a massive use of state power.
That's a slippery slope argument.
Exactly. The concern is that if we allow court-ordered forced medical treatment in the community, will it be used increasingly as a tool of social control? Will we use it to just quietly manage marginalized populations rather than actually providing robust voluntary social support systems?
Which is a totally valid fear.
It is. Now, the sources do note that an explosion in the misuse of this legal tool hasn't actually been documented. Courts are generally very strict about applying it only to the most severe cases. Still, the ethical tension for the psychiatric nurse managing that outpatient care is immense.
Let's shift to another legal concept that extends into the community, and honestly, this is one that nursing students consistently confuse on exams. And let's be real, practicing nurses sometimes get tangled up in it on the floor too. We need to talk about the legal transfer of consent, conservatorship, and guardianship. Let's make this crystal clear for everyone. How do we keep these two distinct?
It is a vital distinction because it dictates exactly who you, as the nurse, must obtain informed consent from. If you get consent from the wrong person, you are practicing outside the law.
Okay, let's start with a legal guardian.
A guardian is appointed by a judge for someone who has severe disabilities, has been legally declared incompetent, and is completely unable to act in their own best interests.
So to visualize this, a guardian is like the absolute CEO of the patient's life. They have total executive control over the whole operation.
That is a perfect analogy. A guardian has global control. They assume total legal responsibility for the patient. They give informed medical consent. They enter into contracts on the patient's behalf. They decide where the patient lives. The moment a court appoints a full legal guardian, the patient legally loses the right to enter into binding agreements.
So let's look at the messy reality of the floor. You have a patient with severe treatment-resistant depression who has a legal guardian. The psychiatrist recommends ECT, electroconvulsive therapy. You, the nurse, bring the consent form into the patient's room. Patient reads it, says, yes, I want this treatment, I understand the risks, and signs the form. Have you obtained informed consent?
Absolutely not.
Really?
That signature is legally meaningless. It holds as much legal weight as if a 5-year-old signed it. The nurse must obtain informed consent directly from the legal guardian. The guardian must be educated on the risks and benefits, and the guardian must sign the paperwork. Proceeding with a major medical procedure based solely on an incompetent patient's signature is a massive liability. It is technically battery.
Wow, got it. So the guardian is the CEO. Now, how does a conservator differ?
Well, terminology can vary slightly from state to state, but generally speaking, a conservator of financial affairs strictly manages the money. To use your analogy, they are the CFO, the chief financial officer.
Right.
They do not have executive control over the patient's body. They just control the budget. They receive the patient's disability checks. They pay the rent. They buy the groceries. They manage the outstanding bills.
But they do not make medical decisions.
Correct. They have zero authority over healthcare. So if a patient only has a financial conservator, that patient is still legally competent to make their own medical choices. The patient still signs their own medical consent forms. If you ask the conservator to sign the ECT consent form, you are violating the patient's autonomy and breaching confidentiality.
So the priority nursing action upon admission, or before literally any procedure, is to aggressively verify exactly what kind of legal arrangement is in place. You have to read the actual court documents in the chart. You cannot just take a family member's word for it when they show up and say, hey, I'm in charge.
Exactly. Verify the paperwork. Know who holds the legal pen.
All right, we're going to transition now from these community boundaries back into the most extreme inpatient scenario imaginable. What happens when that outpatient safety net fails? What happens when a patient is hospitalized in a state of absolute volatile crisis and the nurse's role suddenly shifts from advocate to physical restrictor? We need to talk about the highest risk intervention a nurse will ever participate in: restraints, seclusion, and the least restrictive environment.
The least restrictive environment, or LRE, is the absolute cornerstone of modern psychiatric nursing philosophy. It was the primary driving force behind the whole deinstitutionalization movement. The core legal and ethical principle is this: a patient has the right to be treated in an environment that restricts their personal freedom, the absolute minimum amount necessary to keep them and others safe.
So practically speaking, this means care has to escalate in a very specific, deliberate order, right? You don't just jump to the most extreme measure because a patient is being difficult.
Exactly. You always start at the baseline of maximum freedom. If a patient can be successfully treated in an outpatient clinic, you do not hospitalize them.
Right.
If they do require hospitalization, you allow them freedom of the milieu, which is the general unit where they can interact with others, go to the cafeteria, and walk the halls. If they become agitated or aggressive, your interventions must escalate sequentially, always attempting the least restrictive option first.
Let's walk through the messy reality of that escalation. You are on the floor. You have a patient who is pacing the hallway. They are becoming verbally aggressive, clenching their fists, breathing heavily, and shouting at staff. What is the very first step? Because the textbook just says verbal de-escalation. But how do you actually do that in real life?
Verbal de-escalation is an active, highly skilled clinical intervention. It is not just telling someone to calm down. In fact, telling an agitated patient to calm down is practically a guarantee they will escalate further.
100%. It never works.
As a nurse, you manage your own physical presence first. You maintain a relaxed, non-threatening posture. You keep your hands visible. You position yourself at an angle, not directly chest to chest. And you ensure you always have a clear path to the exit.
And what are you actually saying to them?
You use a calm, low, steady tone of voice. You acknowledge their distress without validating any delusions. You might say, "John, I can see that you are incredibly upset right now, and you look very tense. Let's walk over to the quiet room together so we can figure out what's going on."
Giving them an out.
Right. You offer choices to give them a sense of control. Would you like a glass of water, or would you prefer to sit by the window for a few minutes? You are attempting to talk them down from the ledge of physical aggression.
But let's say that fails. The patient is too disorganized, too psychotic, or just too angry. The pacing turns into throwing a chair against the wall. The danger is rapidly increasing. What is the next step up the ladder?
If verbal intervention fails, you move to the next level of restriction, which is chemical restraint.
Let's define that clearly, because I know exam questions love to trick students on this. What exactly differentiates a chemical restraint from just giving a patient their normal medication?
It is entirely about the intent of the administration. A chemical restraint is a medication, typically a fast-acting antipsychotic like haloperidol, or a benzodiazepine like lorazepam, or a combination of both.
The classic B-52.
Exactly. And it is given specifically to restrict the patient's movement, blunt their behavior, or sedate them when they are exhibiting an unsafe, imminent behavioral emergency. It is an acute intervention for behavioral control. It is not their scheduled morning dose of an antidepressant, and it is not a PRN anxiety medication they requested to help them sleep.
And if the medication is refused, or if it doesn't work fast enough, and the danger becomes immediate and severe, say the patient is now physically attacking another patient or a staff member.
Then and only then do you move to seclusion or physical restraints. Let's look at seclusion first. Seclusion is the involuntary confinement of a person in a specially constructed, locked room. It is usually equipped with a security window or a camera for continuous observation. The room is entirely stripped of anything potentially dangerous. There are no sharp edges, no glass, no cords, no belts. The bed is typically just a heavy mattress bolted directly to the floor.
What is the clinical goal of putting someone in that room? Because to the layperson, it looks exactly like solitary confinement in a prison.
The clinical goal is the immediate containment of severe physical aggression and the drastic reduction of sensory stimulation. When a patient's nervous system is incredibly overwhelmed, perhaps they are experiencing terrifying hallucinations, and every sound or movement in the milieu feels like a physical attack.
Like sensory overload.
Exactly. A barren, quiet seclusion room can sometimes provide the environment they need to safely regain emotional and physical self-control without injuring anyone else.
But what if seclusion isn't safe? What if the patient is actively self-harming? I'm imagining a severely agitated patient who, once placed in that locked room, begins violently banging their head against the wall or trying to bite their own arms. You can't just leave them in there to injure themselves.
You absolutely cannot. Seclusion requires the patient to be safe while alone. If they are actively self-harming, you have reached the absolute peak of the escalation ladder, physical restraint. This takes two forms. There is human restraint, which is a highly coordinated physical takedown where trained staff members physically hold and control the patient's limbs to prevent movement.
And the other form.
Mechanical restraints.
Explain mechanical restraints for us.
These are specialized physical devices, usually heavy-duty ankle and wrist cuffs, that are fastened securely to a bed frame to completely curtail the patient's physical ability to hit, kick, punch, or pull hair. It is the total deprivation of physical movement.
The source material is incredibly aggressively strict about this. Short-term use of restraint or seclusion is permitted only under what exact circumstances?
Only when the client presents an imminent, immediate danger of physical aggression toward themselves or others, and all other less restrictive means of calming the client, the verbal, environmental, and chemical, have been documented as unsuccessful. It is never a first resort.
Ever.
It is never a punishment. It is never to be used because the unit is short-staffed and the patient is being loud or annoying. It is the absolute last resort to preserve life and limb.
Because it's the last resort, and because the deprivation of liberty is so extreme, the legal and safety red flags surrounding restraints are immense. If you are taking the NCLEX, or if you're working on the floor, you have to know the timeline's cold. The Joint Commission will literally pull your hospital's accreditation if you mess this up. Walk us through the strict timelines once those cuffs go on.
The timelines are rigid. Once a patient is placed in mechanical restraints or locked in seclusion, they must have a face-to-face evaluation by a licensed independent practitioner, which means a psychiatrist, a medical doctor, or an advanced practice psychiatric nurse.
Within what time frame?
Within exactly 1 hour of the initiation of the restraint.
Why 1 hour? Why is the mandate so incredibly fast? Because if it's 3 a.m., getting a doctor out of bed to come look at a patient within 60 minutes is a huge logistical hurdle for the staff.
It is a huge hurdle, but it's written in blood. Historically, before these regulations existed, patients were placed in restraints by floor staff and just left there for days without ever being assessed by a physician. People died.
That's horrifying.
They died of strangulation, they died of pulmonary embolisms from blood clots caused by immobility, they died of dehydration and massive skin breakdown. The 1 hour rule ensures that a high-level provider visually, physically confirms that this extreme restriction of human freedom is medically and legally necessary to prevent severe injury. It removes the decision from solely the hands of the floor staff.
And the doctor can't just write an order for, restraints as needed for the weekend, right?
Never. PRN, or as needed, orders for restraints are strictly illegal. An order for restraints is time limited. For adults over age 18, the provider's order must be renewed every 4 hours. For adolescents ages 9 to 17, it's every 2 hours. For children under 9, it's every 1 hour. And every time that order expires, the provider must reevaluate the ongoing need.
So what are the nursing priorities during that time? As the primary nurse, you don't just lock the door, sigh in relief that the chaotic situation is finally contained, and go chart at the desk.
Oh, not at all. Placing a patient in restraints does not lessen your workload. It exponentially increases it. A patient in restraints requires the most intensive, vigilant nursing care on the entire unit. Initially, a patient in restraints requires continuous one-to-one monitoring.
Like someone's staring at them constantly.
Yes. A trained staff member must be physically watching them, either in the room or immediately outside the door, the entire time.
And what are you assessing while you're watching them?
You are conducting rigorous, documented physical and psychological assessments every 15 to 30 minutes, depending on hospital policy. You are checking the skin condition directly under the cuffs for abrasions or breakdown. You are performing neurovascular checks, so assessing blood circulation in the hands and feet. You are checking for capillary refill, skin temperature, and peripheral pulses to ensure the cuffs aren't cutting off blood flow. You are assessing their respiratory status to ensure their airway isn't compromised by their positioning.
What about their basic human needs? I mean, they can't exactly get up to get a drink of water.
Exactly. The nurse must regularly offer food, offer fluids, and offer opportunities to use the bedpan or urinal. You must perform range of motion exercises on their limbs. And crucially, you must document every single assessment, every single offer of food or water, and the patient's response. If it is not documented, in the eyes of the law, it did not happen, and you are guilty of neglect.
I want to bring up something really poignant from the source material regarding the emotional aspect of this. It discusses the severe emotional toll that restraints and seclusion take on the patient. It notes that while the clinical goal of seclusion is to help the patient safely regain self-control, the patients themselves almost universally view seclusion as a punishment.
Yeah, that's a very common experience.
The text says they report feeling angry, bored, frustrated, helpless, and profoundly afraid. They receive the internalized message that they were bad. As a nurse, how do you bridge that massive gap between executing a necessary, life-saving clinical intervention and recognizing the trauma you are actively inflicting on the patient?
It is without a doubt the hardest part of the job. It requires profound self-awareness, deep therapeutic communication, and empathy. As a nurse, you have to constantly remind yourself that this intervention, while clinically necessary for safety, is inherently traumatizing. Your physical demeanor and your words must constantly communicate safety, not punishment. The most critical therapeutic intervention during restraints is to communicate clear, objective, achievable behavioral criteria for release as soon as the patient is able to hear you.
Give me an example of what that actually sounds like. What is the wrong way and what is the right way?
The wrong way is to look at the patient and say, you can come out when you are acting better, or I'll let you out when you calm down. Those phrases are completely subjective, vague, and judgmental. Better means absolutely nothing to a psychotic patient.
Right, it just sounds like arbitrary authority. It's totally unhelpful.
Exactly. The right way, the therapeutic way, is to say, John, you are in restraints right now because you are trying to hit the staff and we have to keep everyone safe. I need to see that your muscle tension is decreased, your hands are unclenched, and you can speak to me in a normal tone of voice without making verbal threats. Once you can do those things, we can start removing the restraints.
You're giving them a literal checklist.
Yes. You give them a concrete physical roadmap out of the trauma. Frequent, calm contact by the nurse provides reassurance that the restraint is a restorative process, not a punitive one.
And the nursing care doesn't stop the moment the cuffs finally come off.
No, it doesn't. Following release from seclusion or restraint, a formal debriefing session is legally required, typically within 24 hours. This is a chance for the clinical team to sit down with the patient and process the traumatic event. You explore what triggered the escalation, you discuss how the patient felt, and you collaboratively plan how the team and the patient can handle things differently in the future.
Like a post-game analysis.
Right. You say, next time you feel that level of agitation building, what can we do? Can you come to the desk and ask for your PRN medication before it gets to the point of throwing a chair? The goal is always prevention.
That is such a vital piece of the puzzle. It brings the humanity back into the equation. Okay, let's transition now. We've talked extensively about restricting physical movement and bodily autonomy. Now we have to examine the restriction and the mandated release of private information. Let's explore the boundaries of secrecy. We are talking about confidentiality and the duty to warn.
Confidentiality is the absolute bedrock of the therapeutic relationship. If a patient does not believe their secrets are safe with you, they will not tell you the truth and you cannot treat them. Medical confidentiality is governed by IPA, which went into effect in 2003. We all know IPA protects general health information, but mental health, psychiatric, and substance misuse records have even stricter, hypervigilant protections baked into the privacy rules.
The source text mentions a really interesting and somewhat tragic side effect of this hyper-strict privacy. It notes that while HYPE is meant to protect the patient, it can sometimes painfully isolate family caregivers.
It is a massive challenge, particularly in community and outpatient settings. The strict compliance rules can severely disrupt communication and collaboration between providers and the patient's family. Imagine a family who is desperately trying to support a loved one experiencing a severe manic episode or a psychotic break.
Which is terrifying for the family.
Right. They are calling the clinic, begging for help, trying to give the psychiatrist crucial information about the patient's deteriorating behavior at home. But if the patient, in their paranoia, has refused to sign a hyper-release form allowing the clinic to speak to the family, the provider's hands are completely tied. The nurse cannot even confirm that the patient is a client at the clinic, let alone discuss their treatment plan. The family is left feeling alienated, helpless, and completely locked out of the care process.
So how does a skilled nurse navigate that? Because you can't break the law, obviously, but you also know the family is a crucial support system.
The text suggests proactive education. You educate clients and their families about privacy regulations early on, during periods of stability, before a crisis occurs. You encourage the patient to sign limited release forms when they are lucid. And when dealing with distressed relatives during a crisis, even if you cannot give them clinical information, you can always listen to the information they are providing.
Oh, that's a good point. IDPA doesn't stop you from listening.
Exactly. And you can offer general, non-specific support and education about mental illness to help them feel heard rather than stonewalled.
The text also briefly highlights emerging privacy risks with telehealth services. As psychiatric care moves increasingly to virtual platforms, ensuring environmental privacy, like making sure a domestic abuser isn't listening just off camera during a therapy session, and ensuring technological security is a massive new frontier for evidence-based nursing practice. But I really want to spend significant time on the most heavily tested, most dramatic, and most ethically fraught exception to confidentiality in all of medicine.
The duty to warn.
Yes, the duty to warn. This doesn't just come out of nowhere. It stems from a very specific real-world legal case, Tarasoff versus Regents of the University of California from 1976. This is a chilling story. Walk us through the narrative of what actually happened.
It is the foundational case in psychiatric law, and every clinician must know it. In 1969, a graduate student named Prasenjit Poddar was seeing a psychologist at the University of California, Berkeley. During a confidential therapy session, Poddar, who was suffering from severe paranoia and delusions, confessed to his therapist that he intended to buy a gun and kill a young woman named Tatiana Tarasoff when she returned from a summer trip to Brazil.
Wow.
Yeah. He felt she had rejected him, and his obsession had turned violently homicidal.
So the therapist is sitting in a room, bound by medical confidentiality, and his patient just explicitly stated a plan to murder a specific named woman. What did the therapist do? Did he just keep it a secret?
No, the therapist actually recognized the extreme danger and did take action. He contacted the campus police and requested that they evaluate Poddar for an emergency involuntary hold. The police went to Poddar's apartment, detained him, and questioned him.
Okay, so the system worked. The police intervened.
But here is where the tragedy unfolds. During the police interview, Poddar presented as entirely rational. He was calm, he denied any intention of violence, he promised to stay away from Tatiana Tarasoff, and he essentially convinced the police that the therapist was just overreacting. Because he didn't seem actively dangerous in that specific moment, the police released him. The therapist's supervisor then directed the therapist to destroy his notes and not pursue the commitment any further.
And what happened to Tatiana Tarasoff? Did anyone call her or her family to say, hey, there is a man who bought a gun and told a doctor he plans to kill you?
No. No one warned her. No one warned her parents. 2 months later, shortly after Tatiana returned from Brazil, Prasenjit Poddar went to her home and brutally murdered her.
My God, that is awful. And so her parents sued the university and the psychologists.
Yes. The parents filed a massive lawsuit. They argued that the clinical team had a legal and moral duty to warn their daughter or warn them of the explicit threat against her life. The legal defense was that doing so would have violated medical confidentiality. The case went all the way up to the California Supreme Court. which ultimately ruled in favor of the parents. In their decision, the court issued one of the most famous and impactful rulings in legal history, they said. Protective privilege ends where public peril begins.
Protective privilege ends where public peril begins. That phrase alone tells you everything you need to know about the hierarchy of ethics. Life supersedes privacy.
Exactly. The court fundamentally changed mental health practice forever. The ruling established that mental health clinicians have a legal, affirmative duty to warn identifiable third parties of threats made by clients, even if those threats were discussed during a strictly confidential therapy session.
How?
You cannot hide behind HIPAA if someone's life is explicitly on the line.
Now, let's apply this directly to the messy reality of the floor and to the logic of nursing exams. Because students get tripped up on differentiating threats all the time. Let's look at a scenario. You have a patient admitted for severe schizophrenia. They are pacing the hall, deeply paranoid, looking over their shoulder, and they mutter to you, "I'm going to get them before they get me. They are all out to destroy my life, and I'm going to kill them first." Does the nurse immediately pick up the phone to warn someone?
No. And here is the clinical nuance you must understand. To trigger the legal duty to warn, very specific criteria must be met. The danger must be serious. The means to carry out the threat must be plausible and available. But most importantly, the target must be identifiable and accessible. Vague, generalized paranoia about an ambiguous them or the government does not trigger the duty because there is no specific third party to warn. You cannot call the entire city and say, "Watch out."
But let's change the scenario. The patient comes to the nurse's station and says, "When I get discharged tomorrow morning, I am going straight to my garage, getting my hunting rifle, and I am going to drive to my former boss, John Smith's office, and shoot him in the head for firing me."
That absolutely, undeniably triggers the duty to warn. The threat is severe and lethal. The means, the rifle, are stated and plausible. The target is explicitly identifiable, John Smith, and the target is accessible. Protective privilege has just ended.
Now, as the floor nurse hearing this statement, what is your priority action? Are you the one pulling up John Smith's phone number on Google and calling him from the nurse's station?
Typically, no. Your primary nursing duty is the immediate upward communication of the threat. You must strictly and accurately document the exact statement in the patient's chart, using direct quotes. You must ensure the patient is in a safe environment, perhaps moving them to closer observation. And you must immediately, urgently report the explicit threat to the attending psychiatrist or the clinical treatment team.
So it's a team process.
Right. The actual decision, the legal mechanics of breaking confidentiality, and the physical act of contacting the police or warning the third party are usually carried out by the psychiatrist, the psychologist, or the hospital's legal risk management team. But the nurse is the critical first link in that chain. If you fail to document and report it, you are liable.
Okay, let's move right into Section 5, when things go wrong. Because failing to navigate these tight legal constraints, whether we are talking about improper use of restraints, breaching confidentiality when you shouldn't, or failing to warn when you should, leads directly to professional and legal liability for the nurse. We need to talk about torts.
Right. Torts. In legal terms, a tort is simply a wrongful act that results in injury, loss, or damage to another person. It is a civil wrong, not a criminal one, meaning it usually results in financial lawsuits rather than jail time. We divide these into two main categories in nursing practice: unintentional torts and intentional torts. Let's start with unintentional. This primarily includes negligence and malpractice.
I want to push back here for a second because I think a lot of people use these terms interchangeably. What is the actual difference if I make a simple mistake on the floor? Is that malpractice? Where does a simple error cross the line into a massive lawsuit?
That is a great question. Negligence is a very broad term. It is defined as failing to do what a reasonable and prudent person would do in similar circumstances. If you don't shovel your icy sidewalk and the mail carrier slips and breaks their arm, you are negligent. Malpractice, however, is a specific, elevated type of negligence applied strictly to professionals, like nurses, doctors, and lawyers. It is professional negligence.
Okay.
To successfully prove malpractice in a court of law, a patient's legal team has to prove that 4 distinct, specific elements all existed simultaneously.
Let's break those 4 elements down
Yeah.
using a clinical narrative, because honestly, that's the only way it sticks. Let's use the scenario of 15-minute suicide checks.
Perfect example. Let's say you have a patient admitted for severe depression with active suicidal ideation. The provider orders 15-minute safety checks. The first element the lawyers must prove is duty. Was there a legally recognized relationship? Yes. You were the nurse assigned to that patient for that shift. You had a legal duty of care.
That makes sense. The second element is breach of duty.
Exactly. Did you fail to conform to the established standard of care? Let's say you get distracted by an alarm in another room, you get busy chatting at the desk, and you miss the 2 p.m. and 2:15 p.m. checks. But not wanting to get in trouble, you retroactively chart that you performed them and the patient was safe. You have severely breached your duty. You did not do what a prudent psychiatric nurse would have done.
Oof. The third element is injury or damage.
Right. Did the client suffer a real, provable physical or psychological loss? In our tragic scenario, during that 30-minute window where no one was watching, the patient attempts suicide by hanging in their bathroom. They are discovered later, resuscitated, but they suffer a severe, permanent, anoxic brain injury. The injury is undeniable.
And the final element is causation.
This is often the hardest to prove, but in this case, it is clear. Did your specific breach of duty directly cause that injury? Yes. If you had performed the checks as required by the standard of care, you would have interrupted the attempt, and the brain injury would not have occurred. Your failure to monitor directly caused the opportunity for the harm.
Duty, breach, injury, causation. If all four are present, you are looking at a devastating malpractice judgment. Now let's pivot to intentional torts. These are not mistakes. These are voluntary, deliberate acts that result in harm or the fear of harm. I really love unpacking the difference between assault and battery because students almost always mix these up, and they are guaranteed to show up on exams and in real-world disciplinary hearings. Let's use a tangible clinical example.
It is the most classic point of confusion in nursing law. Assault involves any intentional action that causes a person to reasonably fear that they are about to be touched in a way that is offensive, insulting, or physically injurious without their consent. Assault is the threat. It is the deliberate creation of apprehension and fear. It does not require physical contact.
So paint a picture for me. What does assault look like in a psychiatric setting?
Let's say you have a patient who is being verbally loud and uncooperative, but they are not an imminent danger to themselves or anyone else. A frustrated nurse walks into the room holding up a syringe of haloperidol, points it at the patient, and aggressively says, "If you don't shut your mouth and get into bed right now, I'm going to hold you down and give you this shot to put you to sleep."
The nurse hasn't actually touched the patient. They are just standing in the doorway.
Correct. But the nurse has intentionally caused the patient to fear an unwarranted, forceful chemical and physical intrusion into their body. The threat of violence is real to the patient. That action right there is the intentional tort of assault.
And battery.
Battery is the execution of the threat. It is the actual harmful, offensive, or unwarranted physical contact. Actual physical injury doesn't even need to occur. The unwarranted touch itself is the violation. So if the nurse actually follows through on that threat, grabs the unconsenting patient, physically restrains their arm without a clinical emergency or a valid legal order, and injects the medication against their will, that physical act is battery.
The threat of the shot is assault. Forcing the shot into their arm is battery. What about false imprisonment? How does that differ from lawful seclusion?
False imprisonment is the unjustifiable illegal detention of a client. This is where those hyper-strict rules around restraints and seclusion we discussed earlier come rushing back into play. Lawful seclusion is an emergency intervention for imminent danger. False imprisonment is using that exact same locked room for the wrong reasons.
Like what?
If the unit is short-staffed, and a patient is wandering the halls singing loudly and annoying the nurses, but they are not violent, not aggressive, and not a danger, and the staff puts them in the locked seclusion room simply to keep them out of the way so the nurses can chart in peace, that is false imprisonment. It is using physical restriction for staff convenience rather than clinical necessity.
So what is the fix here? When you look at the sheer volume of legal landmines, malpractice, assault, battery, false imprisonment, duty to warn, how does a nurse actually survive and thrive in this environment without constantly fearing for their license?
The source text outlines it perfectly, and it really comes down to professional discipline. You practice strictly within the scope of your state's Nurse Practice Act. You collaborate constantly with your clinical team, never make massive ethical decisions in a vacuum. You use established evidence-based practice standards. Most importantly, you document thoroughly, objectively, and accurately. But the ultimate shield against liability is your mindset. If you consistently prioritize the patient's legal rights and human welfare above everything else, the legal liability essentially takes care of itself.
That brings us beautifully to the final major concept in our outline, Section 6, the philosophy of care. Because the law dictates what a nurse must do, But ethical frameworks guide a nurse through the murky gray areas of what they should do when the law isn't black and white. Let's talk about ethical principles and the insanity defense.
Ethics are the philosophical theories we use to decide what is morally right or wrong. In healthcare, we generally operate under two main, often competing ethical theories, utilitarianism and deontology. Utilitarianism is entirely focused on the outcome. It bases decisions on the concept of the greatest good for the greatest number of people. You look at the consequences of an action to determine if the action itself was right.
And deontology.
Deontology is rule-based. It largely ignores the outcome. It says decisions should be based on whether an action is morally right in and of itself, regardless of the consequences, based on duty and moral rules. And under deontology, we have 6 core ethical principles that act as the compass for nursing practice.
Let's run through those 6 principles, but let's apply them to a messy clinical reality. Don't just list them. Let's say you have an elderly patient with severe dementia on the unit. Their spouse died 5 years ago, but the patient is currently crying near the nurse's station, asking you where their husband is and when he is coming to visit.
This is a perfect scenario to highlight ethical friction. The first principle is autonomy, the right to self-determination. But an advanced dementia patient has lost much of their cognitive autonomy. The second principle is beneficence, the duty to promote the good of others and take actions that help the patient. The third is non-maleficence, the absolute requirement to do no harm.
So what do you actually say to the crying patient?
Well, this brings us to the fifth principle, veracity, the duty to be honest and truthful. If you prioritize veracity above all else, you look at the crying patient and say, your husband died 5 years ago.
But if I do that, the patient is going to experience the raw, agonizing trauma of learning their spouse is dead all over again for the first time in their mind. That feels like I'm violating non-maleficence. I am actively causing psychological harm.
Exactly. And that is the ethical dilemma. Do you prioritize veracity, telling the truth, or beneficence and non-maleficence, comforting them and preventing emotional harm? Many dementia care experts advocate for therapeutic fibbing or distraction in this specific instance, essentially prioritizing beneficence over strict veracity to reduce suffering.
That makes total sense.
To round out the 6 principles, we also have justice, which is treating all people fairly and equally regardless of their background or diagnosis, and fidelity, which is the obligation to honor your commitments. If you tell a paranoid patient you will return in 10 minutes to check on them, fidelity demands you are walking through their door at exactly 9 minutes and 59 seconds. Building trust requires unshakable fidelity.
I want to provoke a thought here regarding utilitarianism versus deontology. If we look at the very first thing we discussed today, involuntary commitment, locking someone in a psychiatric hospital against their will, forcing chemical restraints into their body, that seems like the ultimate violent clash between these ethical principles.
It absolutely is. It is the defining ethical conflict of psychiatry. From a strict deontological view, involuntarily committing a patient is a severe, almost unforgivable violation of their autonomy. You are completely overriding their self-determination. But if that patient is actively suicidal or homicidal, utilitarianism steps in to justify the action. The legal and medical systems argue that enforcing non-maleficence, preventing death or injury, and beneficence, promoting clinical safety, legitimately overrides the individual's autonomy in that specific moment of crisis. The societal good of keeping them and others alive outweighs the profound harm of restricting their freedom. It is never an easy decision. It is a heavy, burdensome ethical dilemma by definition.
Let's touch on a legal concept that sparks an immense amount of ethical debate, largely because the general public completely misunderstands it: the insanity defense.
The absolute most important thing to know about the insanity defense, especially if you are a nursing student, is that insanity is a legal term, not a medical or psychiatric diagnosis. You will never, ever open the DSM-5 and see a diagnostic code for insanity. It is a legal argument used in a courtroom to assert that a person should not be held criminally culpable for their actions because a mental disease or defect severely compromised their faculties at the time of the crime.
The text mentions different legal tests for this. How does a jury actually decide if someone is legally insane?
States use different criteria, but the most famous and widely used is the M'Naghten rule. It essentially asks 2 questions. At the time of the crime, did the defendant understand the nature and quality of the act they were doing? And if they did know what they were doing, did they know that it was wrong? For example, if a patient with severe schizophrenia kills someone because their delusion convinced them the victim was a demon trying to harvest their soul, they did not know the act was legally or morally wrong. They believed they were acting in self-defense against a monster. Another standard is the irresistible impulse test. Could the defendant control their conduct, or did a mental disease completely obliterate their ability to resist the impulse to commit the crime?
What is the public perception versus the reality of this defense? Because if you watch crime shows or the evening news, it seems like every defense attorney throws this out there to get their client a free pass.
The public perception is entirely skewed. The public believes the insanity defense is used constantly, and that violent criminals use it as a loophole to just get off and walk free. The clinical and legal reality is the exact opposite. It is used in less than 1% of all felony cases, and it is rarely successful. It fails about 75% of the time it's attempted. The criteria are incredibly difficult to meet. And if a defendant is found not guilty by reason of insanity, they don't go home. They are committed to a high-security forensic psychiatric hospital, often for a period much longer than the prison sentence they would have received. In fact, public outrage over the defense is so high that 4 states, Idaho, Kansas, Montana, and Utah, have abolished the insanity defense entirely.
Dealing with clients in a forensic setting who have committed horrific crimes, or dealing with civilian clients who are making life choices you fundamentally morally disagree with, brings up a massive issue for nurses, the requirement for intense self-awareness.
It is the hallmark of a professional. As a nurse, you are a human being. You have your own values, your own religious beliefs, and your own moral compass. But your professional duty requires you to act in the patient's best interest, even when their choices directly conflict with your personal values. The source material gives a very stark, challenging example. Imagine a patient who is experiencing profound psychiatric distress and grief over their recent decision to have an abortion. The nurse caring for them must be able to provide empathetic, therapeutic support to that patient, regardless of the nurse's personal, moral, or political stance on abortion.
But what if the nurse's beliefs are so strong that they feel they cannot hide their judgment? What if they feel sitting with that patient violates their own moral conscience?
Then the nurse has a professional ethical duty to recognize that internal limitation immediately. You cannot let your personal beliefs compromise the patient's care, and you cannot inflict your judgment on a vulnerable person. The correct action is to step away and quietly find a colleague or a charge nurse who can step in and provide the non-judgmental care the patient requires. Recognizing your own biases and managing them safely is what separates a technician from a true healthcare professional.
Okay, we have covered an immense, staggering amount of ground. We've navigated from the 1970s asylum reforms through the trap of voluntary AMAs, deep into the trauma of physical restraints, and all the way to the Supreme Court ruling on the duty to warn. We are moving now into Section 7, the 20% that matters most. This is our high-yield masterclass summary. If you were listening to this right before walking into your NCLEX or right before badging onto the psychiatric floor for your first clinical shift, this is the cheat sheet you need etched into the front of your brain. Let's rapid-fire the absolute must-knows from today's deep dive.
I will give you the top 4 absolute non-negotiables. Number 1, the must-know legal principle, the least restrictive environment. This principle dictates every single nursing intervention you make. You always choose verbal de-escalation over chemical restraint. You always choose chemical restraint over mechanical seclusion. The only exception to moving sequentially up that ladder is if there is immediate lethal danger that requires bypassing the lower steps. Always choose the path that preserves the maximum amount of human freedom.
Number 2, the must-know safety risk.
Restraints and their timelines. This is your massive liability trap. Restraints are for imminent danger only, never for convenience. If you apply them, you must secure a provider's face-to-face evaluation within exactly 1 hour. You must implement continuous one-to-one monitoring. You must assess and document skin integrity, neurovascular circulation, and emotional state every 15 to 30 minutes. If you remember nothing else about safety, remember the unforgiving strictness of restraint documentation.
Number 3, the must-know exception.
The duty to warn, established by the Tarasov case. Remember this rule. Patient confidentiality is absolute and heavily protected by HIPAA unless the patient makes a specific, plausible threat to an identifiable and accessible third party. If they do, protective privilege ends where public peril begins. Your priority nursing action is to document the exact quote and report it immediately to the attending psychiatrist.
And finally, number 4, the must-know liability trap.
Confusing assault and battery. Assault is the threat. It is creating the fear of an offensive touch, like saying, if you don't stop yelling, I will hold you down and give you a shot. Battery is the execution. It is the actual physical touch, actually holding them down and pushing the medication without a legal emergency or consent. Know the difference and avoid committing both.
Incredible. We've taken the entire dense legal and ethical landscape of psychiatric nursing and distilled it down to its absolute core. Wrapping this up, the big takeaway for you, the listener, is that psychiatric nursing isn't just about passing medications on time or running therapy groups or charting side effects. It is about being a staunch, unwavering defender of human rights in some of the most complex, chaotic, high-stakes, and emotionally charged environments imaginable. You are the final safeguard between a vulnerable patient's liberty and the immense, overwhelming power of the medical and legal systems.
It is a profound responsibility. And as we look to the future of healthcare, that role is only going to get infinitely more complicated. I want to leave you with a final thought to mull over as you continue your clinical practice. We talked extensively about the duty to warn and how it currently relies on a patient rubbily expressing a specific threat to a clinician. But right now, massive healthcare systems are actively integrating predictive analytics and artificial intelligence into electronic health records. What happens when an algorithm, analyzing a patient's admission history, their social media footprint, their vital signs, and their medication adherence, determines there is an 85% statistical probability that a patient will commit a violent act upon discharge?
Oh, wow. That is wild to think about.
Will an AI algorithm one day dictate a legal duty to warn? Will a computer's prediction be used to legally justify an involuntary commitment before a threat is even spoken? And if a machine predicts danger, what happens to the core nursing principles of human autonomy, self-determination, and the presumption of innocence?
That is a chilling, fascinating, and terrifying question. Because at the end of the day, it brings us right back to that dizzying paradox we started with in the hallway. How do we balance the absolute mandate to heal with the terrifying power to strip away human freedom? It's a tightrope, and it requires the very best of your clinical judgment, your empathy, and your courage. Thank you for joining us on this deep dive into the legal and ethical issues in mental health care. Keep questioning the rules, keep fiercely advocating for your patients, and we will catch you on the next deep dive.